All right, there we go. Got it. Okay, well, really appreciate everybody who is able to tune in for today's event. It's been a few months actually since the development alumni team here at the School of Nursing hosted one. So we wanted to rekindle our virtual events here in the summer and then continuing on into the fall. First and foremost, even though I recognize several names here on the call today, I'll introduce myself. My name is Pam Lowe. I'm the Senior Director of Development here at the school. And as I'm going through just a few introductions before I hand things off, I certainly welcome any of you who are on the call today to feel free to use the chat feature and introduce yourself and your affiliation with VCU and the School of Nursing. It's always nice to know where folks are coming from and why you're interested in attending today. But moving on to today's topic. So today, discussing the School of Nursing's research initiatives are our featured guests. And first we have Dr. Amy Salisbury, Professor and Associate Dean for Research, Scholarship, and Innovation. She currently oversees the school's research faculty, projects, and funding, and she'll provide an overview of the research department. We also have Dr. Ingrid Pretzer-Aboff, Associate Professor in the Department of Adult Health and Nursing Systems and Senior Nurse Researcher, who will discuss innovative methods of treating Parkinson's disease. And wrapping up is Dr. Lana Sargent, Assistant Dean of Practice and Community Engagement, who will discuss vulnerability in older adult populations. And so before I hand things over to our speakers today, just to go through a couple of housekeeping items so everyone's aware, we've hit the record button, and that's a way for us to be able to share this event on our school's YouTube channel. And it's also a way for us to be able to share this event for some folks who were not able to tune in today. And you are only going to appear on this recording if you are speaking. So please know that. And after each of our faculty have shared their updates on their projects, we will open up the floor for questions. I know we had at least one pre-submitted question, which I will address first. And then after that, you all will be welcome to use the chat box or unmute yourself to ask any questions that you might have for them. You could also private message my teammate, Talise Owens, if you'd like to submit in that way. And also, I'd like to just introduce my team very quickly, who's on the event today. We have Laura Keller, and Laura is our Alumni Engagement Coordinator, and she works on connecting and engaging nursing alumni to our school. She's waving at you. And we have Catherine Stein. She's our Scholarship and Stewardship Specialist. She handles our scholarship process, coordination with our scholarship recipients, as well as stewardship initiatives. And then Talise, who handles all of these events and more. She's in charge of our donor acknowledgements, and she helps plan these events as well as reunion, and she's our development specialist. Now, without further ado, I'm going to hand things over to Drs. Salisbury, Pretzer-Aboff, and Sargent. As I said earlier, please welcome yourself, introduce yourself if you'd like in the chat box, and I will let Dr. Amy Salisbury take things from here.
Thank you, Pam. Oh, going too fast. Okay. So since we were introduced a little bit, I'm going to tell you just a little bit about my background and what I do here, and go through a little bit of the overview of the School of Nursing's research from the past year. And if there's time, I think we should have a little bit of time. I'm just going to introduce two newer studies that are, I think, great examples of what we're trying to do with our research program at the VCU School of Nursing. So I am the Associate Dean for Research and a professor in the School of Nursing. And I have the pleasure of overseeing the Office of Research, Scholarship, and Innovation. You can see here this picture. It's a great fun group. My research administration core really makes this job a delight. And then it's also one of the keys to the success of our faculty in research and scholarship because they support every aspect of what we do. Uh, Biobehavioral Research Laboratory is also supported by this office, and that is headed by Teresa Swift-Scanlon. A biostatistics core led by R.K. Ellswick, and the Langston Center, which had been led by Michael Bly, who has recently stepped down in preparation for retirement, and we are looking for a new director right now. So I came to VCU about 2 years ago, right as the pandemic was uh, getting in full swing. And so I came from the Northeast in Rhode Island, where I spent 20 years doing research in the prevention of child psychopathology. As a nurse clinician, nurse practitioner in child psychiatry, it was my wish to try to do some impactful research that might prevent child psychopathology. And I proceeded to do this through transgenerational risk, perinatal mental health, and did a lot of work in terms of sleep development from the fetal period through adolescence, particularly through longitudinal work. And more recently, focused a lot on prenatal exposure as a way of getting at what kinds of risk may impact child development and where we might be able to intervene to make things better. At VCU, I'm currently working on my first pilot project through a PERC award from VCU to look at sleep in infants with prenatal opioid exposure so that we can try to help understand how their sleep may be impacted and how to support babies and their families in that transition to home, which can be very difficult. And the future research for me within the school is really focused on maximizing our impact through integration. I've really changed my focus coming here to VCU and have really embraced the community engaged research that's going on here and hopefully you'll see later on when I present our studies that uh, I'm really excited about what's going on. So last year we started to look at our research and strategic mission and what the plan would be, where are we headed? And when I came, it was pretty clear to me that we had a behavioral science track and we had a health system science track. And there wasn't a lot of integration between the two of those. And it seemed to me that we really should be trying to bring all of that together. So in talking with our faculty, I think a lot of people were feeling the same way. And so we've tried to bring an integrated model to our scholarship so that we can take the skills and expertise of our various faculty across practice, education, and scholarship so that they can all come together and benefit from each other. At the same time, to really also embrace interprofessional models. And I think most of our faculty are doing an amazing job with that. And because we can't function and get the best to our communities without that. And the other piece of that is, to keep doing the work that the School of Nursing has been spearheading in terms of community engagement and reducing barriers by bringing our work to the community and really developing trust with those communities. And a focus on holistic wellness and health equity for individuals, for families, for the workforce, and for systems. And I think we have seen, and certainly this is not due to just this past year, the growth that we've had has been a collective cumulative impact. But we have seen growth from 2020 in a $7.9 million funding this year. And we're so excited to be able to have that kind of success across our school, our scholarship. And one of the other things that's very exciting is that if you can see in these taller bars, this is our amount of federal funding from 2019 through 2022. And in the bars to the right of those is our amount of non-federal funding. So as the non-federal funds have gone down, the federal funds have gone up. And you'll see in this dark orange that there's indirect dollars associated with that. And those dollars go to support VCU at large and also our infrastructure. So it's very important to have that kind of federal funding for sustainability, for education of our students, for the entire mission that we have. So this is really exciting that we've had this great success.
Hey, Amy,
Yeah.
you might touch on this. Maybe it's coming up or in this next slide. Your slides are a bit small. Is there any way you could just briefly share with us on that previous slide what some of those dollar figures were?
Oh, are they really showing up small?
They're on my screen. It could look different on others, though.
It may be because I'm sharing my entire screen. Hold on just a sec. Is that better? And are you seeing the slides and not
It's
the?
I'm seeing the slides for sure. They just look a little bit small on my end. I don't know if anybody else on the call is seeing them a little bit bigger. But anyway, I just thought I'd ask if you could provide just a couple of highlights there.
Sure, and I purposely didn't because this is a little, I think
Ah,
Christina Midge, I think she's on the call.
oh,
This is probably from May, so it's not complete, but this is 3.5 million total in 2022 of federal dollars. I think that's a little lower than actual, but probably fairly close. Where in 2019, it was just over a million for both direct and indirect dollars.
got it. Well, I appreciate you sharing. Quick note for those of you who receive our Connections magazine, there, which just dropped, by the way, in the past week, you will see mention about some of these dollar figures as well within the magazine. All right, Amy, yours again.
I was trying to see if I could zoom it somehow for you. It's just ironic because my screen is very large, but I think that's why it's showing up small. So ranking is not everything, but it is certainly helpful when you're trying to recruit faculty and students. So this is the Blue Ridge Institute for Medical Research ranking for schools of nursing, and in the yellow is where VCU is. In 2020, we were ranked number 45 out of 75, so about the 60th percentile. And in 2021, we moved up in ranking to 32 at the 43rd percentile. And I'm just putting in these orange bars as a comparison to another Virginia school, just to show that we are really making nice progress, I think, in terms of where we're headed and in our success. This ranking is based largely on those federal funding dollars and mostly from NIH. So it really is not the only rank that we need to pay attention to, but it's certainly one indicator. And the goal for 2022, which won't come out until February of next year, is hopefully less than 30 or less than the 39th percentile. It'd be great if we were in the 20s someday, but we'll take our baby steps getting there. So as I mentioned, this model that we have for our school, I just wanted to show you the breadth of research going on here in the School of Nursing. And as Pam mentioned, we do talk about this in the article. We have faculty who are working all across the lifespan from infancy through our older populations and are really looking at all kinds of neurodegenerative disorders, genomics, chronic disorders, using newer technology and mobile health. And a lot of the work is focused on getting this research and the impact of it to our communities and inviting them in and having trust in research so that we can build good connections for making sure that everybody is included in research and can benefit from the outcomes. And this also includes our quality and safety and workforce analysis. We have faculty who are doing amazing work in the hospital systems and the community to try to improve our educational models, how we support the future of nursing, as well as using innovation and technology. And then another very important piece is how we promote the holistic health and equitable health by assuring that all of the work that we do and the evidence base that we develop is actually implemented in an equitable way. When we're starting to do this through a team science model, we have 4 teams that have evolved from our work over the past year, and it's not to put boxes around these, but really, we really want to bring these things together. But we have to start with at least groups that are working on things. And I'm happy to say that within each of these boxes, so to speak, or teams, we really have representation from folks in the different types of specialty within the nursing school. And in the future, we'll be bringing in more and more of our interprofessional colleagues. So our strategies for sustaining research growth and to ensure high impact of our research, here's a few things that have happened in the past year and that we're planning. So new faculty hires for 2022. We had originally set out to hire maybe one experienced researcher. Well, we've just hired 3 newer research faculty into our program who are just going to be starting with us this fall. I'm very excited about this. I think growing our own, and these are just dynamic candidates, and I'm really excited that they'll be joining us. And so we really need to step up our structured mentoring programs, and we're working on that now so that we can have the right support, not just for our newer faculty, but also for faculty that are moving into new areas of research or working in teams in a different way. So we're trying to make sure that we have everything in place that we need to support these changes. Additional resources that we're bringing in, a scientific writer, and we've had some of that support over this past year on an ad hoc fashion. Templates and management plans, things and tools that our faculty and staff can use to help support the scholarship. We are again going to have a research and scholarship retreat this year that will bring everybody together so that we can plan out the next year and then the next few years and where we need to head to meet the needs of our communities. And again, integration of scholarship and education across programs. And by that, I mean curriculum programs. How can we embed our scholarship and how we do research into the fabric of our curriculum at even the undergraduate level? I've talked to a lot of undergraduates in the past year who are very interested in, getting that practical experience, getting their practice going, but still want to hold on to a thread of research. And so I think there's a need and an interest in trying to make sure that stays connected together. And training grant, that's our big goal for the next couple of years, is we really want to make sure that we have the resources and funds to be able to support a growing program with more PhD students and more students interested in scholarship. So just to highlight to you some of the exciting new grants that have come about this year. We've had an NIH F31 training grant, which is a grant to support our graduate student, Stephanie Buxhoverden, mentored by Teresa Swift-Scanlon, on exploring biomarkers of sex-based disparities in relapsing multiple sclerosis. And to my knowledge, this is the first NIH training grant that we've had, at least recently in the School of Nursing. So this is very exciting. The plan is to have more students submit these kinds of applications so that we can help to support them more in their research. And going along those lines is 2 NIH diversity supplements, one of them from Dr. Pretzer-Aboff, who will speak after me, and HRSA, so another federal agency that supports the kinds of work that are going on across healthcare. We've had 3 applications this year, and all 3 were funded. We had an amazing year in these types of applications. The NFLP is for our leadership program that's Suzanne Ammeringer submitted for a renewal. Carla Nye, who is one of our non-research faculty who does a good amount of work within scholarship, and she and her team, she has a team of researchers, of faculty working with her that goes across through the health system to be able to support the workforce there to have us, and they're calling it strength and caring because they're really trying to work with leadership for leadership styles and how they can better support the nursing workforce within specific areas of the hospital, especially those that are high stress. And the project of mobile health that I hope to share with you in just a few seconds, led by Pamela Parsons. And the Recover Project, again, if there's time, I don't want to take any time away from my two colleagues today, but if there's time, I'll tell you about our Recover project because it's very exciting. Another core study and an example of one that could be a base for a lot of work that could go on to support our mission. And we didn't write this application, but the Institute for Women's Health submitted an application for a Birch Award, which is a grant that supports mentorship and some scholars to actually take their work to the next level in terms of women's health and gender studies. And I'm happy to say that Ana Diallo, one of our faculty members, is one of their first scholars. So we're very proud of her achievement of that, and for the faculty that we have involved in this project who will be mentors and advisors. So I'm just going to spend a couple of minutes before my colleagues tell you about their work to just touch briefly on these larger projects that have just been funded. The Recover project has had press. You can find that out there. We just had a news story on ABC and in the Richmond Dispatch. So there are some press releases out there, and there's a great website that I'll show you on the slides. So I wanted to focus a little bit more on the HRSA Mobile Health and Wellness Program because we really haven't talked about that yet. It's something that I'm very excited about, and I think really demonstrates how our faculty have come together to work on a project that's going to have big impact. So the Mobile Health and Wellness Program, and that might sound familiar to those of you who have known what's been going on in the School of Nursing for a while, because this is a take on Pam Parsons' project of the Richmond Health and Wellness Program. It's really taking that program on the road, so to speak. And I'm not going to go into a lot of detail, but I just want to give you sort of the structure of this, because it just got funded in July, so this is really new. But I did want to show you how our model of coming together has really paid off, and so to speak. If you look at the names here, this is Pamela Parsons and myself, Dr. Bly, Genevieve Beard, Kim Battle, Kathy Falls, Kimberly Davis, Ana Diallo, and Garvey Dobbins. These are all faculty from the School of Nursing. There are others too. This is interprofessional. There are representatives from other places outside of the school who are going to help us on this program. And I'll show you in a second, it goes even beyond that. But just within the School of Nursing, we have research faculty here. We have practice faculty, people who primarily teach, folks who have expertise in psychiatry, um, uh, geriatrics. I mean, it goes across so many levels, and it's so exciting to see everything come together. I was really honored to work with this group to put this grant application in, and is so excited we're able to actually do the work. It is going to be involve us going to 2 urban sites with this mobile unit and 2 rural sites throughout Virginia, where we'll be bringing this health and wellness care coordination program to all of these areas 1 day per week, starting in the first year. And then in the second year, we will be adding a partnership with the CON FQHC, or a Federal Quality Health Clinic, to be able to bring primary care to our rural areas out in Tappahannock and in South Hill. And the other exciting piece of this is that it also involves community partners and education partners. So we'll have the Richmond City Health District helping us more locally, the Guilford Church, because we need a place to actually bring these vehicles to and park them so that we can set up shop, so to speak, have a tent that we I don't have yet, but we is in the works so that we can expand our space to outside of the vehicle. Bay Area Agency in Tappahannock, and the Essex YMCA in South Hill. And then the last piece another layer of this is that we have our associate degree programs also helping us here, because we're not just bringing the care coordination and primary care to these areas, we're also bringing our students, because we're having education as a part of this has been an integral part of the Richmond Health and Wellness program for a while, and that is certainly going to be the case here across undergraduates, NP nurses, as well as our associate degree nurses. And so we'll also have Rappahannock Community College involved with their nurses as well, nursing students. So stay tuned for more on that study. The Recover Project is an NIH initiative that is nationwide to research COVID. And this is the tagline, researching COVID to enhance recovery. And we're really talking about post-acute sequelae from COVID-19, or PASC, otherwise known as long COVID. And this is a project that I lead with Patricia Kenzar. This is the website I mentioned, recovercovid.org. You can get a lot of information on this website. They really have done a nice job and are very community involved. The general public has been invited to participate in the study design, feedback all along the way. And as you can see here, there are lots of sites across the nation, and we are just one of many, but we are the lead hub for our 3-site consortium that is enrolling children 0 to 25 years of age, their caregivers, and all in all, there'll be about 10,000 involved nationwide to look at PASC and the impact of the pandemic on development. So there's a lot of moving pieces to both of the studies that I presented. There's a lot of opportunity for growth, even just within these projects, and education. So I'm really excited that we have these 2 projects as a basis for bringing together practice, education, and scholarship. So I'm going to hand it over to Ingrid Pretzer-Aboff, who's going to tell us about her research.
Thank you. Okay, I want to share my screen. Can you see that? You see the whole screen big enough? Okay, because I got 2 monitors and they confused me. So my name is Dr. Ingrid Pretzer-Aboff. Thank you for the introduction previously. I have just a little more to add of information about myself and the research that I do. For the last 20 years or so, I've been working with Parkinson's patients. It's an older population of patients, and I have worked in the clinical and then the hospital setting, the clinical setting, and now in the research setting for 15 years. I really focus on research that enables or improves function, quality of life of patients with Parkinson's. So, and I've also recently I say is about 13, 14 years now, I've been working with medical devices that help people with motor skills, which is a big problem in Parkinson's, being tremor and walking, and fell into a group of scientists that we all got together between India and University of Delaware and started talking about the role vibration therapy plays in this population. So I'm here to share with you, first group is going to hear this. Our latest study was funded by the Michael J. Fox Foundation. And it was to look at the role of vibration, see if we could improve gait and balance in people with Parkinson's. So while I have this picture up here, I'm holding a tactor. These are the vibrators, C2 tactors, and we have 2 of them. We put them immediately in the ankle, and we also put one in the toe bank of the shoe. And this is just a beach shoe, a walking shoe. And patients love it, and they get to keep it at the end without the tactors, but they're very happy. Around the ankle is really the computer device, the wearable part, the collecting data, the battery, and all we need in it so that we could control this device remotely. I work with Dr. Leslie Cloud and R.K. Ellswick, our biostatistician. So this is a single site study. We did this at used to be called the Nail Center. Now it's the Short Pump Pavilion that we do this study at. And it was a 2-phase study. The first phase of the study really was about looking at the vibration and how it works with PD patients. I've done this study 4 or 5 times in different places, University of Delaware and in India. And each time we find that it helps people. We change our metrics. It's like it's helping people, but then it's also not helping some people. So working with the Michael J. Fox Foundation, they heard stories, anecdotal, qualitative stories, also that vibration is very helpful. So we decided maybe it has to do with the dose, the frequency of the vibration, perhaps, or the amplitude of the vibration. So frequency is how quickly it vibrates. Amplitude is how much it displaces skin. And that's measured in millimeters. So we wanted to know if we mess around, that sounds so scientific. If we change the metrics, are we going to see a difference? We also wanted to know if there's a difference between patients that have mild disease and those that have more moderate to severe disease. We also wanted to know how long does the patient have to actually wear this device for it to show effect. Once we found those parameters, we did phase 2, the study is we used that information and we conducted a randomized control trial. So this is phase 1, using a central composite design of response to surface methodology. This is a statistical analysis, and it helped design this study. We put 13 patients with moderate disease, mild to moderate, and 13 participants with moderate to severe disease. So we had 2 groups. Each of the groups completed 8 walking sessions. Each of those sessions is 22 minutes long. And you can see along the bottom, they go through little phases. So first we collect data with no vibration turned on. Then we turn on the vibration, have them walk for 6 minutes, and then we build in a 2-minute break. We do that for a total of 18 minutes of walking with vibration on. Some people needed more breaks than just 3. Other people didn't want to take a break, but we asked them to sit still for a little bit. We turned off the vibration and we collected data. So the data we collected was without vibration in the beginning and without vibration at the end. That was 1 walking session. All the sessions occurred in a week, no more than 2 in a day, and they had 2-hour break between that. We sent them out to lunch and they usually came back in the afternoon. We were right by the mall and several people liked that. Or at least their spouses did. Everybody got vibration, but it was set to 1 of 9 different settings. So it was randomized. This is what the first group looked like. This is stage 2 description, stage 3 description. I'll talk about the combined. 88% were male. It notoriously is that way when we work with Parkinson's patients, that the male patients come in. Female patients tend to be harder to find and less available to us to recruit. This is a distribution of the race. So actually 1 person was Asian, 1 was Black, 10 were Caucasian, and 1 was Hispanic. The population of patients that we had 42% had deep brain stimulation, and 88% of them were deemed fallers. So they fell more than once in 6 months. And the average age is 69.6. That was our first group. So I'm going to skip a lot and jump into our results. So remember, I was saying that we wanted to look at the frequency and the amplitude of the vibration to see if there was a magic place where everybody seemed to do their best. Well, we looked at the functional ambulation profile. That's a combination of metrics, the speed of walking ratio, their gait variability index. Patients with Parkinson's have very variable gait. 1 leg shorter, 1's longer in terms of steppage. Speed is different. So that's a gait variability index. And then we looked at the total distance. Again, we looked at stage 2 and stage 3, and these are the combined results. We found, looking at our primary outcome, the FAP, that we did indeed find a frequency that was optimum. So that made us very happy, because that supports that there is an optimum dosage. So 200, you're getting secret material now, 275 hertz was the frequency, and the amplitude of how much it displaced the skin was less important. It was more variable. So you could see the numbers are changing. It's 0.55 millimeters. And just to give you a sense of, you see how all these are 275. When we have our statistician in our group look at these numbers, we thought this is the high end of the vibration. This in terms of speed, it is very possible that we could go higher and get better results. But we were limited by our C2 tactor, could only go to 300. So this is giving us really valuable information about the dosage. I did mention to you that we wanted to look at how long it takes to see an effect, a positive effect of when they wear the vibration. I can tell you the dark scale, the dark bars are pre-vibration for that episode, and the light gray ones is the post. So if we follow the post on the stage 2, the mild disease Parkinson's patients, we could see after the 4th stage of walking, they started leveling off. So that gave us good information because it's a very long study to bring them in 10 times. So we could bring them in 4 times for this reaction to see if we can see this. It's interesting though what happened with stage 3. This is stage 3 patients. They just kept getting a little bit better and better and better over time. We never plateaued. So it's very likely that they just need more time, and it would make sense because their disease is further along. Because of this, and because this took 10 days, we didn't have the resources. We spoke to Michael J. Fox, and we thought, this is during COVID time, we would just take all this information and bring it into our second phase of the study using only stage 2 patients. So our conclusions for the first study is that there really is an optimal dose response to treatment for 275 hertz and 0.55 millimeters for the amplitude on all of these metrics that we looked at. In the Hoehn and Yard stage 2, the less severe patients, stabilization of outcomes occurred after the 4th treatment. And in stage 3, they just kept improving, but at a much slower rate, and it just took longer. We also found out that the device we were using from Resonate Forward LLC, which is a company that I own part, and I have to tell everybody that, was safe, it was tolerated, it could show some improvement with relieving gait disturbances in people with Parkinson's disease. So this was the first time we had output that was so stringent that we could say this made it better. So that's exciting for us and Parkinson's patients, of course. Anybody have questions over the phase 1? You can interrupt me anytime. Phase 2, we took all that evidence that we found in phase 1 and we flipped it into phase 2 of the study. We took a whole set of new patients and then we randomized them into what we call a placebo-controlled crossover trial. We used 12 patients. All of them had mild to moderate disease. They're all able to walk on their own. That means without the help of another person. And a couple of them used canes. We had 2 treatment sessions. Treatment A included walking with the vibration, same protocol as the first phase. Treatment B was the same protocol minus vibration. They wore the device, but they did not receive vibration. This is a single blind study, so while I had no idea, RK, the statistician, nobody knew what the patient was receiving except for the patient and the research coordinator who said it. After they had their treatment, and they were randomized into that, after they had the treatment, they had a 2-week washout with no vibration at all. And then they came back to us and they had the opposite treatment. So if they vibrated the first time, then they didn't the second time, and vice versa. So we had each of those treatments were 4 treatment sessions, and it occurred twice daily on 2 consecutive days. And there was no change in treatment session protocol than the first part of the study. This group of patients, there were 12 of them. We have very similar demographics. The age was 71.6, the mean age, well, 69.2. This is a little more representative of the population of patients. Female is 33%, 67% were male. Caucasian was 100%. This was a convenient sample. We brought in people that we had access to and that were around. We also had difficulty with bringing in patients in the space due to COVID. Those were two barriers. Did not have DBS. None of them did, the deep brain stimulator. The majority of them were fallers. Most of them were taking Sinemet. That's the gold standard medication for Parkinson's disease. And 2/3 had freezing of gait. Freezing of gait is a symptom where the patient feels like they want to take a step, but they cannot. Their feet are stuck to the ground. It could last seconds, it could last minutes, but it's very disabling for patients. So we had a mix, but the majority had freeze of gait. Looking at our scales, which were questionnaires or could be like a Berg balance scale of something that's performed in action. We watch them, trained evaluators come in and do the Berg balance scale on them to see if they have any or what degree their balance is disabled. So with all of these metrics, looking at the FOG questionnaire was a little bit of a surprise, but then again, not. This is when people are asked about how severe their freezing of gait is. And we had a 0.08, and for feasibility, we can look at that and say, huh, there may be something there, that there was benefit, they improved. And this was according to what they said about themselves. Then we did have a really quite interesting, I don't have all of this, the scales here, but there is evidence of treatment effect. And you have to stare at this a little bit. I'm going to walk you through it. So the active group that had the vibration is in red. The placebo group that did not have vibration is in blue. And if you look at, and we looked at all the different metrics, and it seemed that all patients had changes and that they were downward trajectories, meaning they were worse, all of them. And then we was thinking about it, that we compared the two of them, we realized that the active group, the red lines, are the ones that got vibration, did not deteriorate as much. The entire team got together and all of us said, this has to do with fatigue. The patients were fatigued. We noticed they were fatigued. We don't believe it was wearing off of their medication because we assured that they took their medication within 30 minutes from start. So we know that the design of the study fatigued them because they walked for 18 minutes. They're not used to that, but we didn't realize to the extent of that. However, in all those metrics also, it had a protective value, the vibration, they did not decline as much. So that's a good thing. So there's no statistical significant changes observed for the metrics that we were looking at, but the downward trajectory indicates worsening due to the fatigue. But those who receive vibration experience less fatigue and decline, and we interpret that as evidence of treatment effect. This is a good slide. This is good. Now, I mentioned that people have freeze of gait, and we thought maybe people with freeze of gait would look different. So we only pulled out those patients. There's 8 of them. So, and we did find that there was a clinically important difference in people who did not, the placebo group, in terms of getting worse, whereas the vibration group did not show a clinically important difference. They saw the same. So there's that protective part again. Stride velocity makes sense. Velocity is just the speed of walking. Stride velocity is the actual stride, how quickly it takes to take a step. And then it follows with freezer gait that the step length we observed increased with people with vibration, and we looked at the left leg, the left foot, and in placebo, it actually got shorter. So looking at just the freezer gait patients, that's what we decided to move forward with in our next study. So our conclusion is we observed a fatigue effect, which was evident across all outcome variables, contributing to the decline in nearly all the outcome measures. And those who receive vibration treatment experienced less of a decline, across the gait measures, suggesting the positive treatment effect. So there are many unresolved issues, and there's much more work to be done. And there's some important questions before we proceed with a larger trial. And one of them is that the mechanism of vibration still is unclear. If it's acting as a sensory cue, reminds people to take a step, which seems the most likely, then habituation is a concern. Habituation refers to the concept of you get used to a stimulus, just like if you have a clock in your home that's tick-tocking, you don't hear it anymore. That's what that refers to. We were funded 2 years ago, we're in the second year now, to an R01 for an NIH grant that is testing a different approach of using vibration. This one's very exciting. We are able to, in the second year, identify freeze a gait before it happens, and then turn on the vibration to abort the freeze a gait. So we're having really nice results already. And then there's one other grant just put in last week. We had the opportunity to look at DBS. There's a new DBS that has stimulators to the brain, and it's giving us some output local field potentials. So we're going to see if we connect the brain waves to the freezing and gait activity of the patient. And if we could link those two, then there might be a dose of vibration that the deep brain stimulator could stimulate the patient's brain with. So that's our cutting edge research right now. And then our next best steps is looking at grants, and we may use both of these approaches using with Parkinson's patients. One, the NIH is more targeted for the freeze of gait, and the other one, it could be just gait metrics and speed, because they definitely got faster. And I'm going to turn over this. Let me stop sharing. And Lana, are you ready?
I'm ready. I'm here. That's amazing. It's nice to be the first to see.
Yeah, you're all first.
Incredible work. So exciting. Ingrid and I share some similar collaborators too. So I'm going to just make sure you can see my slides. Everything look okay to everyone? All right. I'm going to move right into this, but just give you a little background, specifically just kind of my role in fact, what it pertains to and what we're talking about today. Certainly, I know it was mentioned by Dr. Salisbury that we do a lot of interdisciplinary work, and you can see that a lot of what we do here is really to hit on the teaching, scholarship, and research service mission. But I do quite a bit of interdisciplinary research. So that's highlighted here with my affiliate faculty and the School of Pharmacy, in which I teach and do research with the geriatric pharmacotherapy program. And then our IQ program that has just been growing, and you'll see here, this is actually one of my patients and also one of my participants in my research. This is me sitting there with one of our pharmacists who's been a part of the program in the early phases. This is Dr. Obwana, who's now actually the interim dean of the School of Pharmacy. And this model really is and the work that we're doing is really the genesis of the Richmond Health and Wellness Program. Many of us who were early faculty in that program have gone on to grow our own programs of research built off of this community engagement model. And I have to say, I'm really excited that now I've had this opportunity to take on the assistant dean and take on leadership role to continue to see this program develop. And as I've mentioned, I am a practicing nurse practitioners. So many of the individuals I see in clinic are also a part of the Richmond Health and Wellness, but also a part of our research. So there's a lot of synergy in what we do. So I work in geriatrics at VCU Health. The other big part of what supports my work, and I'll show you the pieces of this, is I'm a contracted researcher in the Center for Alzheimer's and Related Diseases. This is a new center. I've been doing this for 4 years. I'll be going on my 5th year. The access that I can get to resources and big data resources to ask big questions that often are really hard to get with primary data collection is where I get to use and utilize incredible resources there. And I'll show you a little bit about what I get access to and also bring to the School of Nursing and our students. The other thing that I want to make note of is the work that we do on service. Virginia has a funded state commission. Is one of the few in the state. So it was a policy push around Alzheimer's and related dementias. We also in our state budget have funding for startup monies for continued work in Alzheimer's and related dementias, which is my area. And so I've been really fortunate on that front to also lead some of the policy changes for the Commonwealth. So this is just an incredible resource for not only research, but just for our state in general. So my research focus actually is on 2 big syndromes of aging. One is called physical frailty, I've defined here for you, and then also cognitive impairment. And early in 2013, early in my work, and I started to recognize the phenomenon with our patients where we didn't see these in isolation. For many older adults, we were seeing them, they experienced both syndromes. And some of my early work in 2014 through 2020 was to define this phenomenon. It was a relatively new phenomenon. Now it's relatively well understood, and I'll explain some of the things that we're doing now to work on this. But we now have good measures for detection of it. We're still working to understand a lot of these predictors and things between mobility and cognition. So there's so much to do in this area. But I will tell you what we're starting to understand is what the Alzheimer's Association describes as a pipeline once this diagnosis gets made. So if proper care isn't done in those early phases, people continue to decline. It's an accelerated decline for individuals who have either one of these or both together. It's even faster. It's a 12-fold increase for functional disability for people who have both. And when that decline happens for a lot of our older adults, there are less supports. So Social Security disability benefits aren't enough to cover the gaps in resources that are needed. And for some people, they're on fixed incomes or the job loss occurs because of these accelerated physical and cognitive declines. And then unfortunately, what we see in the housing units that we work in, because they can't care for themselves, they are evicted or they go to homelessness. And that pathway is the area that we hope to disrupt. We're hoping to disrupt that pipeline with the research that I'm doing. And I'm hoping to disrupt that pathway in 2 different ways. So you see at the top, I have a list of longitudinal big aging studies that I work with at NIH. And so what we're doing here is we're hoping to disrupt that pathway by understanding the biological processes behind what accelerates that pipeline. So often we are, and as a team, using predictive models, lots of machine learning and AI models that we're building, where we put these data together, make a population model to try to predict using individuals already banked genomic data or their clinical data to try to determine if there are factors that we can either reverse or early predictors. And I'll talk to you a little bit about what we're doing. Now, we take a lot of this work here. Actually, this is an enormous resource because the Baltimore Longitudinal Study of Aging just reached its 65th birthday. So these, with this data, we can ask really big questions and get access to really life long or multiple time point questions. Now, out of this work has really the findings that we've had around medication risk and physical function and cardiovascular risk factors. I've been able to create 2
studies that are translational in nature. So one is our TAP study. We call it the Translational Approaches to Personalized Health. And in that study, we're looking at two factors. One is ambulatory blood pressure, so phenotypes, not just a one-time blood pressure that you take at the office, but changes in blood pressure that happen through a 24-hour period. We're assessing if nighttime blood pressure is a risk factor for a long time, uncontrolled high blood pressure at night is a risk factor for cognitive impairment. And we're also looking at how older adults metabolize their medications as a way to match or personalize medication approaches. What I'd like to do today, though, is present a newly started program that actually encompasses on a lot of things that Dr. Salisbury was talking about, as well as kind of touches upon everything that we've learned so far about the syndrome that I was talking to you about. So this is the Richmond Health and Wellness Program. You can take your phone and actually scan this QR code if you're interested in even learning more about the program or seeing more, or I've missed some points along the way. So feel free to scan that. And this is our team. So we have, this is just the starting of our team. I should say we have been, again, this is the basis in a lot of the work we are doing on the community side is within the Richmond Health and Wellness Program and the relationships that we've built through that program. But you can see it's an interdisciplinary team, gerontology, nursing, and neurology. So we have two trained coordinators. We have 40 people enrolled in this study in just the first month. So it took us a little while to get off the ground with our funding, but within the first month, we have 40 people enrolled. So it's pretty exciting. We have one coordinator that's providing services that I'm going to explain to you in a second on the community-based side. So she's working in our section housing buildings out in our community, working in Henrico with our partners there to enroll individuals into our program. And then we have Kennedy, who's working with myself and Brian Berman and the hospital side on the clinic side. And actually we may be extending into the post-acute side, so people coming out after stroke and an acute event into our program. And we call it a warm hug, right? It can't just be one side. We have to hug from all sides. Patients are coming out of the hospital and into the clinic, and so we have to do the whole piece. And so Annie and Kennedy work really closely together because a lot of people are doing both. They're in both places. So these are a lot of the takeaways from the big data that I've been telling you about. We know that brain health or cognitive decline with physical decline is multifaceted. That's why in geriatrics we talk about syndromes. It's not just one thing. This is why it takes more than one discipline to solve these problems. And so I was excited to present the Brain Health Initiative because it really is focused on trying to meet the individual's personal needs. So our intake really focuses on all things we already know, and then we individualize the plan based on what their needs are. We know that physical function is a major part of risk factor for accelerated decline. So we are part of our health coaching, I'll show you in a minute, is about setting goals to prevent that risk, right? I've already talked to you about, we have programs around high risk medications, as well as trying to understand how individuals metabolize those medications so we can really match those medications to the individual so they're more effective. And then I mentioned we have some studies going on around cardiovascular risk factors. But in the Brain Health Initiative, what we're trying to do is touch upon all of these factors. So this is really the biological and clinical side, right? But what we know from social determinants of health is that we can't really move the needle without looking at the structural processes. We can't, we really cannot disrupt that pipeline that I was mentioning without addressing the issues around prevention. And when I mean prevention, we're spending, and I'll show you some of our results, we're spending some time in the community normalizing and breaking stereotypes and stigmas around Alzheimer's. Part of the reason why we have not been able to get to prevention with older adults is they're not as interested or scared or afraid to talk to their providers about this. So we're breaking down the stereotypes, talking to them a lot about how when an individual is screening for their blood pressure, they're trying to prevent heart disease. We do the same thing with their brain health. We want to screen for their brain health so we can try to prevent cognitive decline. We're also working closely with our community partners. We've done that for years, but structural issues really require outside community support. So we've been crystallizing a lot of our community resources so that it makes it easier for us to navigate people to where they need to go. We did that with a Cerner community engagement Cerner grant. That was one of our first grants. They also our community advisory is actually a part of the development of the Brain Health Initiative. So it's an ongoing feedback cycle where they're giving us feedback about the development of this, which is really nice. Also, as we know, there have been significant changes or programmatic benefits for Alzheimer's and related dementias, but they're not reaching everyone equitably. So our services are really focused on telephone based. We're going into the housing units. We're meeting people where they are. We're meeting people in the clinic. And of course, talking to them about enrollment so that their voice can be heard, and so that equitable care really means having access to the research and a voice in that research. So that's the framework that we're working on. So why RHBI? We wanted to know too. One of our first studies was, asking ourselves, and the community, is there a need for what we're doing? So one of my first studies actually that was funded by the PERC, we screened individuals in our environment that we were already working with, 100 individuals without a diagnosis of dementia, and found 49% of individuals had undiagnosed cognitive impairment. These are individuals living alone with very little resources. And that's where we see that both physical and cognitive decline accelerate, and you see that pipeline happen. Again, this is backed up by our state plan, and what we've been finding in conjunction with the Alzheimer's Association is that individuals with that decline are not talking about it. So this really feeds into the Brain Health Initiative and what we're doing on prevention, destigmatizing, community screening. We also wanted to know whether or not community screening for this type of thing, especially in the early phases, was acceptable. And we did find that individuals that we worked with in our first study, we had about an 80 to 90% acceptability. And we're talking about just not global screening. We did full neuropsych batteries on individuals in the community setting. It was very well accepted. We did an event in partnership with Henrico, and we were amazed at how many people were really interested in what they could do for their brain health. So I think the message is getting out that just like we're screening for cardiovascular disease, we should also be doing work on prevention for cognitive decline. So we did use that initial grant funding to find out whether or not, if we put a program like this together, was it even needed? And we found overwhelming support for a need for a brain health initiative here in Richmond, as well as they told us the services that were needed. And so that initial survey is actually what created the Richmond Brain Health Initiative. So we have, and led us to our ACL funding. This funding gives us 3 years of support to develop this program. They just gave us free rein about a month ago, and so we've started enrolling individuals. We have a 3-part goal, which is to focus on people at risk, individuals living with brain health needs, so the people who are rising risk, the people who are already at risk, and those who are caring. So again, I talked to you about that warm hug. It is everybody within that network that we're targeting. So how are we going to accomplish this goal? Well, I will remind you, it's an iterative process. So what we've developed so far has been based off of our stakeholder needs assessment. So we've created the program based off of that. But our funder gives us this opportunity to be extremely flexible and use this feedback cycle to be nimble and change as we go along. We actually have regular check-in cycles that help us to create something, so that at the end, we're creating something that really meets the needs and hopefully potentially disrupts that pipeline I was mentioning to you. So I'm going to quickly just go through the services that we're offering. We're offering care navigation. One of the things that we heard overwhelmingly was when individuals are at risk, or when they want to know someone's already been diagnosed, they're not sure where to go. They don't understand how to navigate the resources. They don't know how to ask for what they need. So our intake actually is very detailed, goes through the process of determining what their specific need is. And then the coordinator, either Kennedy or Annie, as I mentioned, will be working with them as a warm contact to connect them. We've already done this already. We make sure that the need is addressed, and then we document that address. So that's what our funder is looking for, is that need has been addressed, as well as we are. Health coaching, I have about 3 years of work behind health coaching. We've specifically started to move health coaching into the Alzheimer's and brain health realm. This hasn't been here before. It's been used quite effectively in other areas of chronic disease. And we found that it was very effective for individuals with self-reported cognitive decline, the rising risk, as well as individuals with mild cognitive impairment. So this reduces the risk for memory and brain health impairments and address personal health needs. And so we're continuing to evaluate this as one of the arms of this program. The last one I'm really excited about, it really supports caregivers, because caregivers themselves are also at risk for further physical and cognitive decline. And so we have a care consultation program. We have about 12 people actually on our wait list as we start this month. And we are, our coordinators are trained, but we also working in partnership with Riverside Memory Center to deliver this service. And it's a 9-month-long support program. And then we evaluate the outcomes from that program. And so our biggest challenge is actually, lately we just got started, but our biggest challenge is capacity. There are very limited resources. The closest brain health or memory center is UVA, and a lot of our participants, especially our low-income minority populations, cannot get there. Again, we want equitable care and resources. Our current Department of Neurology doesn't have a cognitive neurologist. And so we've been working very closely with Dr. Berman to harness some state funding and on the policy end to increase capacity within our resources, to bring more resources so that we can continue to grow this program and grow the Alzheimer's and related dementia research and care that's happening right here in Richmond. Actually, if you just look right here, this is us right here in the middle for numbers of individuals. And Virginia, if you look at the Alzheimer's Association, is top 2 in the nation for Alzheimer's and related dementias. So we definitely have capacity needs. And then sustainability, we're required by the ACL to sustain this model. It can't go away. So I feel really fortunate that we have a partner between the health system and us that's very committed to making this stay, as well as we're integrating it into the Richmond Health and Wellness program. It's actually a part of their intake now. And then we hope as the Richmond Health and Wellness program grows, that we'll be able to serve beyond urban and maybe move to rural populations, which have their own unique needs with physical function and cognitive decline. So I'll stop there. We hope to replicate this, like I mentioned. We hope that it will continue to grow and just be a part of the research and the care that we're already providing to our local community.
Wow. Well, thanks to you all. This was just so informative and just makes me so proud of what we're doing here at the School of Nursing and what each of you are doing. So I just wanted to first and foremost just recognize that. And I'm seeing some comments rolling in here from Nancy McCain. And if you don't know Nancy, she was one of our faculty members for so many years and has commented here. Before, I also want to be cognizant of our time. We went a few minutes over, and that's okay because we're recording, so we'll be able to share this with folks who needed to hop off of the call. However, Amy, I see that you had posed a question to Lana. If you wanted to share that with her.
Sure. I was just wondering if you were also getting heart rate or heart rate variability when you were collecting blood pressure.
We are, yeah, the 24-hour ambulatory blood pressures, that's been an interesting experience, certainly getting people to put those on and keep them on overnight. But yes, with that, we get an initial blood pressure, 3 blood pressures just sitting, then they wear the device for 24 hours, and that does collect heart rate variability in that process too. And overnight. Mm-hmm.
There's a lot of new evidence coming out about overnight heart rate variability and prediction of risk in a lot of things. And I know that the group that I sometimes get to meet with on Fridays, who are looking at POTS and other types of autonomic disorders, would be really interested in what you're doing.
Yeah, the nighttime blood pressure, I think, is the one that's most interesting, because of course we know about sustained blood pressure, right? All day long blood pressure risk, but the nighttime blood pressure is the area that's sort of the black box, not knowing whether or not it needs to be treated, if it really does cause those long-term outcomes that we see, in particular, the cognitive outcomes. So absolutely, that we're just getting. I don't have those results for you today. We're just finished those phenotyping, and so we'll be doing those results really soon. So we're excited to see what we find.
I can't wait.
Yeah.
Lana, I want to make sure you do take a peek at the chat box. Nancy Langston has shared a nice comment for you.
Thank you, Nancy. It's always good to have you here. It's always been a great supporter of me.
You bet. Well, I recognize I want to be respectful of everybody's time. If anybody, though, has a quick question or a comment, feel free to take yourself off mute, or if there's anything additionally that you'd like to add to the chat box. Going once and twice. All right. So again, a big thank you to Lana, Ingrid, and Amy today for presenting to this group. And again, there were several other folks who I know wanted to tune in. So we'll be able to share and pass this recording on. And I'm trying to think, Talise, I know what you always have teed up as a handy survey that you send out to all of our attendees. It's really a way for us to gauge feedback about the programming that we have, what you might want to see more of or done differently. So your honest feedback is always very much appreciated. Did I miss anything, Talise?
No, I don't think you did. I'll try to get the recording up as soon as I can.
That sounds terrific. All right. Well, everybody, thanks for tuning in, staying on a few extra minutes to hear about all this just innovative and important work that's going on here at the School of Nursing. And we'll see you hopefully at our next event, which is at the end of August.